Welcome to the deep dive. Imagine you're prepping for something big, maybe a surgery, and you know you'll need serious pain control. You might hear about familiar medications, but what if one you thought you knew for, calming nerves or helping you sleep had a completely different, powerful use right there in your spine?
Interesting thought.
That's what we're diving into today. We've taken quite a stack of sources, articles, research, clinical notes, all about using midazolam, that well-known sedative, using it directly in the spinal fluid for pain management.
Yeah, and on the surface, putting midazolam into someone's spine sounds, well, odd. Definitely counterintuitive. But our sources, they really reveal a fascinating story. It's a story of scientific discovery, exploring some surprising potential benefits, but also facing significant safety questions and navigating that slow, complex path to, clinical acceptance.
Right. So our mission for this deep dive is to cut through that complexity. We're going to figure out why this idea even came about in the first place. We'll look hard at what the actual evidence says about how well it works and, critically, its safety profile. And ultimately, we'll try to understand where intrathecal midazolam actually fits or maybe doesn't fit in pain management today. Think of this as your essential briefing, kind of giving you the key insights without getting totally lost in the academic weeds. Let's jump in. Okay, so midazolam, most people know it, right? Given before procedures to relax you, maybe calm anxiety, stop seizures. You get it through an IV, a shot, maybe a pill, even a nasal spray sometimes. Works on the brain. So why on earth would anyone decide to, squirt it into the spinal canal?
Well, that's where the science takes maybe a surprising turn. The whole idea behind putting it intrathecally directly into that fluid space around the spinal cord. It's all about getting the medication right where pain signals are being processed, maximizing its effects specifically on those pain pathways, while hopefully keeping the rest of your body, especially your brain and lungs, kind of out of it, minimizing those systemic effects.
But what's actually down there in the spine for midazolam to even interact with? I mean, it's not the brain.
Exactly. And here's where it gets really interesting. Researchers discovered a surprisingly high concentration of specific receptors. They're called benzodiazepine receptors. They're actually part of the GABA-A receptor family. And they found them located right in the dorsal horn of the spinal cord.
The dorsal horn? Okay, remind me.
Think of the dorsal horn as a major pain processing center. It's like a crucial switchboard where pain signals arrive from the body before they head up to the brain.
Okay, so by putting midazolam right there, you're essentially targeting that pain switchboard directly.
Precisely. And this uses a completely different mechanism than most other pain medications we use spinally.
Yeah.
Opioids work on opioid receptors, local anesthetics, block nerve signals by messing with sodium channels. Midazolam taps into the GABA system.
GABA.
Yeah, GABA is your body's natural off switch, or maybe slow down signal for nerve activity. High levels of GABA activity in that dorsal horn essentially put the brakes on pain signals.
And midazolam, it boosts that.
It binds to a specific spot on that GABA-A receptor, and it makes GABA's natural stop signal even stronger, more effective.
Right. Like if GABA's trying to close a door on pain signals, midazolam adds extra muscle to push that door shut.
That's a great analogy. It makes it harder for those pain signals to get through to the brain. This is exactly why it was explored as a potential opioid-sparing option, or maybe something you could add to other pain meds. The thinking was if you hit pain with different mechanisms, you might get better relief with potentially lower doses of each drug, right? And maybe reduce side effects.
Makes sense.
It definitely came partly out of that ongoing search for non-opioid ways to control pain and avoid problems like, breathing difficulties or nausea that opioids can sometimes cause.
Okay, let's think about how that plays out physically. So making those pain-carrying neurons less excitable right there in the spinal cord, that translates to pain relief just in the areas connected to that part of the spine. Segmental analgesia.
Exactly. It's like a targeted dimmer switch for pain right at the source level. And early studies, even in animals, showed this pain relief. Importantly, they found you could actually reverse the effect with medications that specifically block midazolam's action, like flumazenil.
Oh, interesting.
Yeah, that confirmed it was really working on those specific benzodiazepine sites on the GABA receptors.
Now, our sources do mention maybe some early hints about other possible ways it might work, like maybe involving opioid receptors somehow.
Yes, some initial animal work did suggest it might possibly interact with other systems, maybe even opioid receptors, but probably in a pretty minor way. Some very early animal studies even seem to show reversal with naloxone, which is an opioid blocker.
Right.
But honestly, The vast majority of the evidence, especially with drugs that specifically block benzodiazepines, points overwhelmingly to the GABA-A system as the main player. That's the primary mechanism for its pain-relieving effect in the spine. Those other potential pathways, they're really considered secondary at most, maybe not involved at all at the doses we use for pain.
Okay, so understanding that it works primarily on this GABA system, right at the spinal pain switchboard, where have researchers and doctors actually tried using this in practice? The sources seem to highlight two main scenarios: pain right after surgery, so acute pain, and then certain types of really tough-to-treat chronic pain.
That's exactly where the clinical investigation has focused. And the strongest evidence we have is for using it as an adjuvant.
An adjuvant,
Right.
the helper drug.
Exactly. A helper drug, something you add to the main anesthetic or pain medication, like a local anesthetic or maybe an opioid, to boost its effect or duration. For acute pain after surgery, the typical doses are relatively low, often somewhere between 1 and 2.5 milligrams.
And does adding this, well, sedative actually make a difference for pain control after surgery?
Absolutely. Multiple studies, including well-designed randomized trials and these big analyses that combine data from many studies, they show significant improvements. One large meta-analysis, looking at 13 trials, found that adding intrathecal midazolam could increase the time before a patient first asks for more pain medication by, on average, nearly 2 hours, almost 99 minutes.
Wow, 2 hours.
Yeah, and it also helped reduce pain levels in those critical first hours after surgery and meant patients needed fewer extra or rescue pain meds overall.
2 hours longer before needing more pain relief. That sounds like a really solid clinical benefit. And what's fascinating is the note that it often does this without making your legs feel numb or weak for longer. Why is preserving movement so important?
That's a key advantage, especially in, modern recovery pathways. Getting patients up and moving soon after surgery is crucial for preventing complications and speeding recovery. Many local anesthetics used in the spine can cause significant motor block, make it hard to move your legs, which delays mobilization.
Right.
The fact that midazolam seems to target the sensory pain processing area, the dorsal horn, more than the motor control area, the ventral horn, probably explains this selectivity.
Yeah.
You get the pain relief benefit without that lingering motor weakness, which is a real plus.
The sources also specifically call out its use in cesarean sections. Are there particular reasons or benefits seen in that patient group?
Yes, C-section delivery is a population where it seems to offer some distinct advantages. Studies suggest it provides excellent pain control and, very significantly, helps reduce nausea and vomiting around the time of surgery.
PONV, postoperative nausea and vomiting.
Exactly. And PONV is a major issue after C-sections, especially when you use intrathecal opioids, which are common. One recent study directly compared adding 2 milligrams of midazolam to the standard spinal anesthetic versus adding a low dose of fentanyl, another common intrathecal opioid. They found the midazolam group had longer-lasting pain relief, needed fewer extra pain meds, and crucially had fewer side effects.
Fewer side effects, like what?
Especially less nausea and less itching compared to the fentanyl group. That's a big difference for patient comfort.
Reduced nausea and vomiting.
Yeah.
That's a huge win for anyone, but especially new mothers, right? Is that anti-nausea effect a general benefit when midazolam is used intrathecally as an adjuvant?
It appears to be one of its most consistent advantages, based on the data. That same large meta-analysis confirmed a statistically significant reduction in PONV, an odds ratio of 0.50, which is quite substantial. This antiemetic effect is a major plus, particularly because, as you know, many other effective intrathecal pain medications, especially opioids, are notorious for causing nausea.
Okay, so strong evidence as a helper drug for acute pain, particularly notable benefits like reducing PONV and itching. What about using it by itself for pain? Or for chronic pain that lasts a long time?
Well, for acute pain, using midazolam as the only analgesic agent intralithically, there isn't really much evidence for that. Almost all the studies look at it being added to something else.
Okay.
But for chronic pain, that's where we see some exploration of using it alone. This is mainly in specific, often very challenging chronic pain syndromes, things like severe lower back pain or pain that persists after back surgery, sometimes called failed back surgery syndrome or FBSS. Some studies, particularly by a group led by Dr. Prakaska, have looked at single-shot injections of preservative-free midazolam for these patients, typically doses between 2 and 5 milligrams.
Single shots. And what did they find for those patients living with really difficult long-term pain?
The results from these specific studies suggest that a notable percentage of patients, maybe around 65% in some of these reports, did experience meaningful pain relief.
Meaningful meaning.
Meaning their pain scores dropped by at least half, 50% or more. And for those who responded, the relief could last for quite a while, often several weeks, sometimes even a few months. Though, importantly, the duration varied significantly from person to person. It wasn't predictable.
Mm.
The idea here is that for a patient who has, tried everything else and is still suffering, maybe a relatively simple single injection might offer temporary but significant relief, especially compared to, say, needing a surgically implanted pain pump, which is obviously a much bigger deal, much more invasive and costly.
So it sounds like a potential niche option for a very specific, very difficult group of patients who haven't found relief elsewhere. But you mentioned these studies are open label. What does that mean again, and why is it important here?
That's a crucial point, yeah. Open label means both the patient and the doctor know exactly what drug is being given. There's no blinding, no placebo control group in the same way. The issue with open label studies, especially for something subjective like pain, is they have a higher risk of bias. Placebo effect can be strong.
Right, expectations can influence outcomes.
Exactly. Patients expecting relief might report relief even if the drug itself isn't the primary driver or maybe exaggerates the effect size. So while these results are definitely promising for those specific refractory chronic pain patients, the evidence isn't considered as strong or as widely reproduced as the data for its use as a helper drug in acute pain. It's why it's generally considered a later line or maybe more investigational option in the chronic pain context.
Okay, stepping back a bit. How does intrathecal midazolam stack up against other common medications injected into the spine for pain, like fentanyl, which you mentioned, or another one, clonidine?
Yeah, comparisons get a bit nuanced. The results can vary depending on the study design, the specific surgery, the doses used. Context really matters.
Let's start with midazolam versus fentanyl then. You said C-section studies looked good for midazolam.
Right. In that C-section context, some studies found 2 milligrams of midazolam was comparable or maybe even superior to 20-25 micrograms of fentanyl, particularly in terms of how long the sensory block lasted, and very importantly, with a much better side effect profile, significantly less itching and less nausea vomiting.
But not always better across the board.
Correct. In other surgical settings, some studies have found fentanyl can sometimes provide a quicker onset of action and maybe a longer duration of both pain relief and nerve block compared to midazolam. So you can't just say one is universally better. The choice often boils down to the specific surgical situation, what kind of pain you're anticipating, and which side effects you're trying hardest to avoid. Are you more worried about PONV, or is rapid onset absolutely critical for this case? It's a trade-off.
Okay. What about midazolam compared to clonidine? Clonidine is another non-opioid used ethically, right?
Yes, it acts on alpha-2 receptors. There's less direct comparison data here, but one study did compare 2 milligrams of midazolam to a low dose of clonidine, 30 micrograms, as adjuvants for lower abdominal surgery. And that study found the midazolam group actually had significantly longer postoperative pain relief and needed fewer rescue pain meds compared to the low-dose clonidine group.
Interesting. Any other differences?
Yet another interesting finding was that the midazolam group also had more stable blood pressure and heart rate. They had significantly fewer instances of bradycardia, slow heart rate, and hypotension, or low blood pressure compared to the clonidine group. And those are known potential side effects of clonidine.
Good to know. So if a doctor or, any health professional were considering using this, what are the absolute critical things they would need to know about actually preparing and giving it?
Well, dosages, as we've touched on, are generally in that 1 to 2.5 milligram range when used as a helper for acute pain. And potentially a bit higher, maybe 2 up to 5 milligram for those single shots explored in chronic pain, though 5 milligrams is often cited as a kind of ceiling for non-cancer chronic pain in some practices.
And the big blinking red light warning sign, the one that comes up again and again in the sources.
This is paramount. Non-negotiable. Cannot be emphasized enough. You absolutely, without question, must use a preservative-free formulation.
Preservative-free? Why is that so critical?
Because standard midazolam vials, the ones typically used for IV sedation, often contain preservatives, things like benzyl alcohol or parabens. And these preservatives are known neurotoxins. They are poisons to nerve tissue when injected directly into the spinal fluid.
Oh, wow.
Giving a formulation with preservatives intralathically can cause severe permanent nerve damage or a really nasty inflammatory condition of the spinal canal lining called arachnoiditis. This isn't unique to midazolam. It's a critical safety principle learned over decades for any drug given intrathecally. You have to use preservative-free.
Okay, absolutely clear on that. Is preservative-free midazolam easy to get hold of?
Well, the sources suggest availability has improved over time. while older articles noted it wasn't really formally approved or widely available as preservative-free specifically for this use in places like the U.S. More recent information indicates that preservative-free formulations are available from pharmaceutical manufacturers now.
But there's a catch, right?
Yes, and this is another crucial point. Just because a preservative-free version exists and is available, that does not mean it is approved by regulatory bodies like the FDA for intrathecal use for pain. Doctors using it this way are typically doing so off-label.
Off-label meaning?
Meaning they're using an approved drug for an unapproved indication or route. It's legal, but it means the clinician takes on significant responsibility. They must follow the available evidence carefully and get thorough informed consent from the patient, explaining the off-label status.
Got it. And the actual process of giving it, is it complicated?
No, the administration itself is part of a standard spinal anesthetic procedure. A needle is inserted into the lower back, into that subarachnoid space where the cerebrospinal fluid, CSF, is. You confirm you're in the right spot by seeing CSF flow back. And then the medication, usually mixed with the local anesthetic and maybe other adjuvants like fentanyl or morphine, if used, is injected slowly into the CSF.
Okay. Let's directly tackle the elephant in the room then, the safety concerns. The sources discuss potential neurotoxicity. How worried should someone actually be about nerve damage?
Yeah, the history here is definitely complicated, and it contributes to why it's not universally adopted, I think. Some very early animal studies, which importantly sometimes used formulations that did contain those toxic preservatives, or they used extremely high doses. Those studies did show some worrying changes in the spinal cord tissue, and those early findings, understandably, raised a lot of red flags and created significant hesitation in the medical community.
But the picture has changed quite a bit since then.
Yes, it really has. Later animal studies, specifically using exclusively preservative-free formulations at doses much more relevant to human clinical use, were largely reassuring. And, much more importantly, extensive human studies and now years of clinical experience with the preservative-free version paint a much more favorable picture regarding safety at appropriate doses.
Like what kind of human studies?
Well, there was one large prospective study in humans looking at over 1,100 patients who received 2 milligrams of intrathecal midazolam added to their spinal anesthetic. And they found no increased risk of long-term neurological problems specifically linked to the midazolam itself. Factors like being over 70 or having a slightly bloody tap during the spinal procedure, those are things independently associated with neurological symptoms, not the midazolam at that dose. And meta-analyses, combining data from many randomized trials, also report neurological symptoms as being uncommon, around maybe 1.8%, and importantly, not statistically different from patients in control groups who didn't receive midazolam. Plus, long-term follow-up in those chronic pain studies using single shots generally hasn't shown clinical signs of neurotoxicity either.
So is it fair to say the neurotoxicity concern is mostly mitigated or maybe largely resolved if you strictly use the preservative-free version correctly at analgesic doses?
I think the strong consensus from the literature and clinical experience now is that using exclusively preservative-free formulations at appropriate analgesic doses, those 1 to 5 milligram ranges, dramatically reduces the risk of clinically significant neurotoxicity compared to using formulations with preservatives. That seems clear. However, the historical debate does linger, and the potential vulnerability of nerve tissue means that proving absolute zero risk, long-term safety for everyone in every single scenario is incredibly difficult. That would require massive, very long-term studies, ideally following patients for at least 6 weeks or more, as some have suggested.
And there was that lab study mentioned.
Right, one in vitro study, done in a lab dish, not in people or animals, did hint that midazolam might potentially increase the neurotoxic potential of local anesthetics at certain high concentrations, which just underscores that interactions between drugs given together in the spine can be complex and need ongoing study. It's not always simple addition.
Okay. Beyond potential nerve issues, what are the other side effects people might experience with intrathecal midazolam at these doses?
The good news here is that at the doses used for pain relief in the spine, the systemic side effects throughout the rest of the body seem to be generally quite minimal. This really supports the idea that the drug is largely staying where you put it, in the spinal space, and not getting absorbed into the bloodstream in significant amounts to cause widespread effects.
Like respiratory depression, breathing problems, which you'd definitely worry about if you gave someone a big IV dose of midazolam for sedation.
Exactly. And clinically significant respiratory depression, meaning dangerous slowing of breathing, is reported as very rare or simply not observed in most studies using these typical intrathecal analgesic doses.
Hmm.
One large meta-analysis found 0 cases among nearly 200 patients who were specifically monitored for that outcome across 8 different trials.
That's reassuring.
It is.
Yeah.
But, it's still midazolam is a benzodiazepine with known potential to affect breathing systemically. So careful monitoring is always essential, especially in the initial period after administration.
And effects on blood pressure or heart rate?
Hemodynamics.
Hemodynamic stability, blood pressure, and heart rate staying stable is generally reported as good. Significant drops in blood pressure or heart rate are uncommon with these doses. And as we mentioned earlier, one study actually found it resulted in fewer instances of low blood pressure and slow heart rate compared to a different spinal adjuvant, clonidine.
Okay. What else might someone notice? Well, other reported effects tend to be mild. Some patients might feel a bit sedated or drowsy, but usually it's mild and they're easily woken up or aroused. As we discussed, it's actually notable for reducing nausea and vomiting when used as an adjuvant, which is a major advantage. If nausea is reported as a side effect of the drug itself in the chronic pain studies using it alone, the incidence seems low. And a big advantage compared to using intrathecal opioids is significantly less itching, or pruritus. That's a common and bothersome side effect of spinal opioids.
Right.
Headache is also reported sometimes, but usually at a low rate, and it's generally considered distinct from a post-dural puncture headache, which can happen after any spinal procedure. Oh, and one other thing noted in some chronic pain studies was that a small percentage of patients, maybe around 5%, reported a temporary worsening of their usual baseline pain right after the injection, which is kind of paradoxical but seemed transient.
Interesting. Are there certain people who should absolutely not receive intrathecal midazolam? Contraindications?
Well, because it's primarily used off-label for pain, there aren't formal, universally agreed upon intrathecal contraindications specifically defined by regulatory bodies. However, you'd obviously apply the general contraindications for using midazolam systemically. So if someone has a known hypersensitivity or allergy to benzodiazepines,
Definitely not.
right, or if they have acute narrow-angle glaucoma, or if they're in shock with very low blood pressure, those would generally rule it out. You'd also want to be more cautious, use careful judgment, in certain vulnerable patient populations, like the elderly, people who are very frail or debilitated, those with severe kidney or liver problems, significant pre-existing breathing issues like severe COPD, or maybe certain psychiatric conditions. As with any off-label use, every potential case requires a really careful consideration of the potential benefits versus the potential risks for that individual patient.
Okay. So, given some of these reported benefits, especially helping with acute pain, cutting down on opioid side effect like PONV, it might seem surprising that this medication isn't a standard, widely recommended option everywhere. Why isn't it? What are the hurdles?
Yeah, that's really the core of the issue for intrathecal midazolam and pain management today. The single biggest factor is its predominant off-label status.
Still off-label for this use, despite the research.
Largely, yes. Regulatory bodies, like the FDA in the U.S., for example, have not formally approved midazolam specifically for injection into the spinal space for pain relief. It's approved for sedation and anesthesia via other routes like IV or IM, but not this specific route and indication for analgesia. This means doctors using it this way are operating outside the official labeled indication.
Which doesn't mean it's wrong, but
it comes with added responsibility, right? It requires strong evidence justification based on the available literature and really thorough patient consent where the off-label nature is clearly explained.
And regulatory bodies just haven't moved towards approving it for pain.
Correct. If you look at chronic pain delivered via intrathecal pumps, for instance, only 2 drugs currently have specific FDA approval for that route: morphine and ziconotide. The FDA has even put out general warnings about using medications not formally approved for use in intrathecal pumps, citing risks like dosing errors or pump compatibility issues. Now, that warning is more focused on continuous infusion via dunks, but it highlights the generally cautious regulatory stance around off-label intrathecal use, particularly anything involving continuous delivery over time.
What about recommendations from the big professional medical societies, like anesthesiology groups or pain specialist organizations? Do their guidelines endorse using intrathecal midazolam?
Generally, no. That's another major factor. The sources we looked at consistently note a lack of strong endorsement in the official clinical practice guidelines from major societies, whether in Europe or North America.
So, for example, guidelines on managing pain after a C-section.
right? Those guidelines often recommend intrathecal opioids like morphine or fentanyl as a standard approach to improve pain control. But they don't typically include midazolam as a routine recommended adjuvant alongside them. Some older, very specialized guidelines, like the Polyanalalgesic Consensus Conference, PEDC guidelines, did mention midazolam, but usually way down the list, like a sixth-line option and often only for very specific niche applications, like continuous infusion for severe refractory cancer pain, not for routine post-op pain or non-cancer chronic pain.
So it hasn't really broken into the mainstream recommendations.
Exactly. And the absence of that strong endorsement from leading professional bodies means it just hasn't become a standard go-to treatment that everyone learns and uses routinely. Its use tends to be more within the realm of individual clinical judgment, maybe more common in specialized centers, often reserved for patients who haven't responded well to the more conventional guideline-recommended treatments. And this leads to variability in practice. How and where it's used isn't standardized across the board because there isn't that strong, unified guideline direction.
Okay, so taking all of this and how it works via GABA, the evidence for acute and chronic pain, the really critical safety point about preservative-free, and then these regulatory and guideline hurdles. How do we kind of pull it all together? What's the overall takeaway message about the role of intrathecal midazolam right now? Where does it stand?
It really seems to sit in this zone of maybe promising potential, but definitely limited widespread acceptance. That sums it up pretty well. Its role as an adjuvant, that helper drug in acute postoperative pain, appears to have the most solid foundation of evidence supporting it. When added to standard spinal anesthetics, the studies consistently show it can effectively prolong pain relief, lower pain scores in that initial recovery period, and importantly, provide that very valuable benefit of significantly reducing the nausea, vomiting, and itching that often come with using intrathecal opioids.
And it does that while keeping blood pressure pretty stable and not causing prolonged leg weakness, usually.
Right. Those are significant advantages in the post-op setting.
And the solo use for chronic pain.
Well, using it as a solo agent is much less established for acute pain. There's just not much data there. But for those specific, tough-to-treat chronic pain conditions like severe chronic lower back pain or failed back surgery syndrome, those open-label studies, while limited, do suggest it holds some promise as a temporary relief option for patients who've kind of run out of other effective treatments.
Okay, so if we had to boil down the key benefits again, what are the main selling points based on the evidence?
I'd say prolonging pain relief when added as an adjuvant, potential for using fewer opioids, opioid-sparing, significantly reducing PONV and itching compared to opioids, maintaining good hemodynamic stability, so stable blood pressure and heart rate, and that selectivity for sensory pain block over motor block, meaning less leg weakness.
And the flip side, the big concerns or limitations.
Number one is that historical shadow of the neurotoxicity debate. Even if it's largely addressed by strictly using preservative-free formulations, it still lingers in the conversation and contributes to caution. Number two, the significant obstacle of its off-label status and the lack of formal regulatory approval specifically for pain management via this route. That's huge. Number three, the absence of strong backing from major clinical guidelines, which hinders its widespread adoption. Then there's the need for more consistent, high-quality research data, especially large, blinded, randomized controlled trials, particularly for the chronic pain applications. The current evidence is still a bit heterogeneous. And lastly, the potential for some mild sedation, although usually not severe at these doses.
So putting all that together, where does it seem to fit best in clinical practice today based on the evidence we have right now? Is there a specific clinical niche?
Based on where the evidence is strongest and the risk-benefit seems potentially favorable, its most clear niches appear to be, first, as an adjuvant, adding it to spinal anesthetics for acute pain after surgery. This seems particularly compelling for patients where minimizing opioid side effects is really critical, or maybe for patients known to be at high risk for severe nausea, vomiting, or terrible itching from opioids. It offers a way to potentially mitigate those issues.
Okay, adjuvant for acute pain, targeting side effects. What's the second niche?
Second would be for carefully selected patients suffering from chronic lower back pain or failed back surgery syndrome. But only those who have really gone through extensive multimodal treatment, haven't found adequate relief, and maybe aren't candidates for or simply aren't interested in more invasive options like spinal cord stimulators or intrathecal pain pumps. For them, it might offer a minimally invasive way to potentially get temporary, maybe bridging relief, But this should really only be considered as part of a comprehensive pain management plan after a thorough multidisciplinary assessment. It's not a first-line treatment.
Makes sense.
So, to kind of wrap it all up, intrathecal midazolam works by boosting the body's natural GABA stop signals for pain right in the spinal cord. The evidence shows clear benefits when used as a helper drug in acute pain, improving pain relief duration and dramatically reducing common and bothersome opioid side effects like nausea and itching. For a select group of patients with difficult chronic pain, single shots show some potential for temporary relief, but this is based on less rigorous open-label studies. Safety seems acceptable at these analgesic doses, provided that exclusively preservative-free formulations are used. That's the absolute key. But the historical concerns about neurotoxicity and the need for more long-term safety data definitely persist. And critically, its use remains largely off-label and is not widely endorsed by major professional guidelines, which significantly limits its routine adoption into standard practice.
So what does all of this mean for how clinicians might use it now, and maybe more importantly, what still needs to happen for its role to potentially change or become clearer in the future?
Well, based on the current evidence, I think clinicians can reasonably consider using preservative-free intrathecal midazolam, typically in that 1 to 2.5 milligram range, as an adjuvant in acute postoperative pain, especially when reducing opioid side effects like PONV or pruritus is a major therapeutic goal for that specific patient. For chronic pain, using maybe 2 to 5 milligram as a single shot, that really should be reserved for carefully chosen refractory patients who have failed multiple other therapies, ideally after a multidisciplinary pain team assessment. And always, always, always use the preservative-free version and monitor patients appropriately afterwards.
And that off-label status requires?
It requires a really thorough, transparent conversation with the patient, discussing the potential benefits, the potential risks, the uncertainties, and explicitly mentioning the off-label nature of this specific use for pain. Informed consent is crucial.
And looking forward, what's needed?
The literature consistently, almost universally, calls for more research. There's clearly a gap between the perceived clinical usefulness reported by some practitioners for certain patients and the level and quality of evidence required for mainstream acceptance and formal regulatory approval. We really need more large, high-quality randomized controlled trials with robust methodology comparing it head-to-head with other active treatments of placebo, and including long-term follow-up, looking at least 6 weeks, maybe longer, to really nail down both safety and effectiveness across different patient groups and different types of pain conditions.
What else needs clarifying?
More data is needed on things like optimal dosing regimens, more direct comparisons against all the other potential adjuvants like clonidine or dexmedetomidine, understanding the cost-effectiveness, and even exploring technical aspects like formulation stability and compatibility, especially if anyone were considering continuous infusion more broadly, though that seems less likely given the current landscape. Plus, understanding those complex drug interactions in the spinal space, like that potential interaction with local anesthetics suggested by the in vitro study, is also important.
And ultimately, for it to ever become a widely recognized standard option like, say, intrathecal morphine.
It would likely need to demonstrate a consistently strong and favorable risk-benefit profile in those rigorous large-scale studies. That's what would be needed to even pursue formal regulatory approval for specific pain indications. Simply showing it's, not worse than existing options might not be enough to overcome these significant hurdles of its off-label history and the associated safety concerns. It probably needs to show clear, demonstrable advantages, maybe significantly better pain relief in a certain difficult situation, a clearly superior safety profile for key outcomes like respiratory depression or PONV, or perhaps proven utility for patients who truly have no other viable options left. That's a high bar.
Wow. This has been a really fascinating deep dive into a medication with quite a surprising dual identity. From sedative to spinal analgesic, it really shines a light on how complex and sometimes slow the process can be to bring a new way of using a drug, even a familiar drug, from promising research into standard clinical practice, even when there seem to be clear potential benefits for patients. So after digging through all this, what really stands out to you? Is it the power of targeting pain via a completely different mechanism, the GABA system, compared to opioids? Is it the absolute critical importance of something seemingly small but actually huge, like whether a drug formulation contains preservatives or not? Or maybe it's just that slow, often challenging journey from an exciting study finding to broad acceptance and formal approval by regulators and guideline committees.
That's a great question. For me, I think it raises a really important broader point, doesn't it? In an era where we are desperately seeking more effective non-opioid pain solutions, and we're grappling with this epidemic of chronic pain that's often so resistant to treatment. How do we, as a medical community, appropriately balance the necessary caution required for patient safety with the drive to explore and potentially adopt promising therapies that could make a real difference for suffering patients? Especially when those therapies sit in this kind of gray zone of off-label use and incomplete evidence. It's a tough balancing act. Definitely something to think about long after this conversation.
Absolutely. A crucial question. Well, we hope this deep dive has given you, our listener, a much clearer picture of intrathecal midazolam, the science, the evidence, the controversies, and why it's still a topic sparking significant discussion and debate in pain management circles. Thanks for diving deep with us.